Hello and welcome again to our CMHC podcast series, and this is podcast 3. Um, I have my colleagues, Dr. Deborah Clegg and Dr. Greg Pressman, with me, and this is now part 3 of our podcast series on sodium and cardiovascular risk. And Dr. Deborah Clegg will be talking about a patient with sleep apnea and comorbidities and highlight some very practical approaches to addressing hypertension as well as holistic patient cardiovascular risk reduction by considering some of the issues related to diet and behavior and medications. Deborah?
All right, so I'm going to just go ahead and summarize. I have a very quick case, and this is very similar to a case actually that was just presented in the New England Journal of Medicine. It's that it just came out in April of 27 of this year, and again, the title of the article in the New England Journal of Medicine is "Dietary Sodium Restriction in Patients with Heart Failure." And so my case, unbeknownst to me, is very similar to the case that actually just came out in the New England Journal of Medicine. So this is the case. This is a 52-year-old African-American male who presents with hypertension. He has a blood pressure of 180/92. He also has type 2 diabetes. He has bilateral knee osteoarthritis and untreated sleep apnea. His medications include amlodipine for his hypertension, metformin and empagliflozin for his diabetes, ibuprofen and effervescent paracetamol for his bilateral knee osteoarthritis. His diets consist of processed foods for lunch and dinner due to time constraints. And so my questions to you as the audience is, should you A, discontinue the amlodipine for his hypertension and find a replacement therapy? You might think about that again because he's clearly not well controlled with his current hypertensive medicine. B, you might refer the patient to a sleep specialist for the treatment of his sleep apnea. Again, this patient is notable though because this individual also has hypertension. So were you just to go to for sleep apnea, you might not treat the hypertension. So I might want you to think a little bit more about that. C, might you discontinue the effervescent parameciol and ibuprofen and find suitable lower sodium replacements? Also, might you refer the patient to a nutritionist to be counseled on reducing his dietary sodium sources of sodium and increasing his potassium intake? Our last question, or our last potential answer, is might you think about A and B, which would be change his hypertensive medicine and send him to a sleep specialist? Or might you consider the best choice would be actually B and C, which would refer him to a sleep specialist as well as discontinue his medications, some of the medications that are much more sodium offensive, and actually refer him to a nutritionist to counsel him on not only a low sodium diet, but I might advocate also a significant increase in his potassium consumption, much more analogous to the DASH diet. So that's really why I wanted to have this case, just so we could have a little bit of a discussion about this person is not unusual. This is a very typical individual. So let's highlight a couple of the features for this person. Number one, they're 52 years of age, so they're slightly older. As this person gets even more older, more age, that might be even more concerning. Again, this individual is an African-American male. Now, we talked a little bit about the fact that race, ethnicity, and the like actually influence whether they're salt sensitive or not. Given the fact that this individual is an African male and has a significant salt intake, you might question whether this person might actually be someone who is very salt sensitive. There are data to suggest that when you put African Americans on a salt reduction and a DASH diet, they have a significantly greater reduction in overall blood pressure. So again, these individuals in the presence of a DASH diet and a slight sodium restriction can have significant improvements in overall blood pressure, again, just by those dietary changes. And so just wanted to highlight again that calls out to us that we need to pay attention to race as well. Again, this person has a hypertension that's uncontrolled, as well as then he has these other conditions, and then have been given medications specifically that increase the overall load in addition to his dietary intake. So again, this might be someone we would want to refer for medication changes as well as dietary changes. So I open it up to my esteemed colleagues to see if they have any other comments or thoughts.
This is a very interesting and actually very complex case. And as you said, there's so many things to think about, and it highlights the fact that we really have to see patients from a holistic perspective. That, oh, his blood pressure is high, just give him an antihypertensive. No, there's so much more going on. I really like the case in terms of how instructive it is. I'll start off, and Greg, you can follow. The thought is, well, why isn't he on an ACE inhibitor or an angiotensin receptor blocker? And generally, in an African American, would be less likely to use one of those drugs. I think amlodipine is quite reasonable, and we may, if we did add a drug, I would probably go for a diuretic. But Greg, you go ahead. Your thoughts on this?
I think certainly in an African American male, a diuretic would be a good thing for helping with his hypertension, but treating his sleep apnea might help. Certainly, changing his diet and his high sodium medications would help. Maybe we can treat his pain another way. Maybe he can get injections. Maybe he can get knee replacements even. But with things the way they are now, he is surely headed for trouble and at very high risk for cardiovascular events. So I would actually opt for an F answer to choose from, being all of the above and a referral to orthopedics.
No, I think that point is really well taken, because in this individual, because they now have this knee problem, the likelihood of them exercising is going to be extremely low, right? So it's such that we talked about the fact that diet and exercise are incredibly helpful with respect to obesity and hypertension. This person won't be able to engage in the exercise. Also, they're on an SGLT2 inhibitor, which has some of that cardiorenal benefit, but we'll have to also continue to watch that as well. But I think definitely a medication change is in order for this individual to control their hypertension. If we added the diuretic, though, would we still be able to look at urinary serum sodium? I understand that when the diuretic's on board, urinary sodium is no longer as telling as it would be if there wasn't a diuretic on board. Is that the case?
Greg, do you want to chime in on that? Or?
So the diuretic is going to increase sodium excretion, but I don't think we would measure that clinically. I think it would be much more practical just to have him sit with a dietitian so he understands the sources of sodium in his diet. And I think you'll get a lot of benefit that way.
I couldn't agree more, right?
And going back to the choices, I would be inclined to go with B and C. And the reason is that, we could give him a medication and treat his apnea, but I would be inclined to do one thing at a time, treat his apnea, lower his salt, and see where his blood pressure is. So one of the things that I would be, maybe not so much in him, but taking all of the salt away, if it's successful, in terms of taking away the paracetamol, taking away the ibuprofen, lowering his dietary sodium, and treating his apnea, all of that could potentially bring his blood pressure down substantially, as you showed us, Greg, that in hypertensive people, sometimes a behavioral modification can drop your pressure up by as much as 11, systolic pressure. And then treating his apnea may give him a few more millimeters of mercury drop. Then see where he is, and then decide on whether you want to add a drug and which drug to add. It would be my approach. But I can see that, in a busy clinic, I wouldn't argue with giving him a thiazide diuretic, and sending him to the sleep clinic, and taking away all the salt medications, taking away the ibuprofen, and having a nutritionist talk with him seriously.
Absolutely. I think it's time for him to see the nutritionist for sure, to really,
Yes.
really reduce the processed foods and increase the fruits and vegetables on that more DASH-like diet would be outstanding for this individual. So thank you. That's my case.
This was very, actually, this took a lot of what we talked about and just put it all into one not uncommon patient presentation. So,
thank you.
Any more thoughts, Greg? Any other thoughts on this?
I think we've summarized it pretty well.
Yeah. So I'm going to conclude by saying that, I guess some of the messages, and I'd like you guys to add on to the messages that I've taken out of this, is that when we're seeing a patient with high blood pressure or with narcolepsy or sometimes with arthritis, we ought to be fairly cognizant of looking carefully at what medications they're on and also what their diets are like. I'm not sure that we ask very much about diets as part of our regular evaluation. I know in our cardiovascular health clinic, the preventive clinic, we certainly do, but I'm not sure if that's a standard part of most workups. I'm not sure how many people do ask about sleep and sleepiness and sleep apnea and disruptive snoring. Despite, you know, us asking about diets, I had really learned about bread. And I learned that bright colored processed foods, Deborah, are the worst, right? The attractive ones.
Absolutely. Right. And that's why, taking a dietary history is so incredibly important. But we have to really ask our patients, okay, so you had, a ham sandwich. What type of ham, right? It's not just asking the simple questions because they need to understand it's the way that that was processed. It was the way that it was cooked. You could say, did you have rice for dinner? Yes, but was it instant rice? There's so many different variations. And so coming up with some food frequencies that really highlight were your foods processed, I think is going to be the way to go to really change the sodium content or intake.
So it's really the opposite for vegetables because bright colored vegetables are great for you. Bright colored
Absolutely.
processed food is terrible for you.
Exactly. So yeah, so switch from the brights into the vegetables and away from the processing.
Yes.
And I think perhaps we can learn from our patients who are very interested in their diet and, quote, eating healthy and living a healthy lifestyle. And perhaps we don't pay enough attention to that. I have to say, in preparing my talk, I was very impressed with the magnitude of blood pressure lowering that can be achieved with non-pharmacologic interventions.
Those were very impressive data. I
Yes.
think that's fantastic.
Great. Well, Deborah, Greg, I hope we can do this again in the future. But it's been very instructive for me, and I've no doubt our audience has learned a lot, lots of new facts, lots of important and practical and relevant and actionable new facts that I've learned. And so thank you very much. I do appreciate your time and all the work you put into putting this together.
Thank you. It's been an honor to be with both of you. Thank you so much.
Thank you.